Hello to everyone. We are starting. Please join in. So we are starting the session soon. Hello to everyone. Dr. Makhima, Dr. Shrusti, how are you all? Yeah, so we are starting and we are doing our session live. Please join in. Very important. Yes. So how are you all? I hope you're doing good. Just starting in a minute. So within some time I'll start the class. Today is the last session of medicine. We have done 3 systems already. So we've done endo, we have done neuro, and we have done half of the cardiology. We'll do cardio today, finish. Then do the pulmonology and the nephro and other minor systems. Okay. Hello to everyone. Good evening. Yeah. So today is third session and the last session of medicine. So I think I'll start now. Since all of you are here, let other people also join in. All good. Everyone is good. Everything is good. I hope you are studying properly and not taking any tensions. Yes. So very soon you'll have NEET PG exam and then there'll be FMG exam. So everything is going as per the plan only. So don't have to worry. Everything would be clear and done. Okay, I think I should start now. So yes, so I'm just telling you, okay, whatever links you have, you can watch them, and you can even watch the older ones in case you want to study. Okay, like example, if you need some older videos, you can use old one. It's not going to change much. 99% it remain the same. Like example, someone want to watch pharma, they can watch my pharma last time session, anesthesia last time, psychiatry last time, so PSM also last time. I will take fresh, but in case you are not getting this fresh class now, what you can do is you can watch the old one and do. Okay, yeah. I'll take patho, don't worry. Okay, because we'll be taking classes daily now. Okay, so I plan to take daily session so that we are able to finish the syllabus on time without any problem whatsoever. So that is our whole sole idea is. Chalo, okay. So let's start. See, PDF is already there in the so description. Click the description, you'll get the PDF. Okay, yeah. Gynecology, I think you can watch the old session in case we are not able to take the live within few days. Okay, but my plan is to take surgery next, and after surgery we are going to go for our OBG. Okay, surgery and OBG. Chalo. So let's continue. Let's study the medicine. Where is our medicine? This physio, I think I've already uploaded. If not, I will do it, but I think I did upload. Okay, otherwise after this session I'll upload. Okay, with Prakash. Okay, so let's continue. We are at the medicine. We are discussing heart failure. Let's discuss the heart failure. We were here. Okay, so there are 2 kinds of heart failure, right heart failure and the left heart failure. Now if there's a right heart failure, it is most likely caused by left heart failure. So most common cause is left. So when there's a left heart failure, the lungs are congested because of blood not going out of them. It put extra burden on the right ventricle, eventually causing failure of the right ventricle. So that is why what they ask you, most common cause of right heart failure is the left heart failure. Also by pulmonary diseases like COPD, and this is called as cor pulmonale. So what is cor pulmonale? It is a right heart failure due to the diseases in the lung, plus any pulmonary or tricuspid valve defect can causes again this. Even mitral stenosis, this again put extra burden, so it causes pulmonary congestion and edema. And whenever lungs are congested, again it can lead to problem. Okay, then inferior wall MI causes the involvement of right ventricle. Then ventricular fibrillation or IV drug user, we have infection, infective endocarditis. So fibrillation or anything. Okay, now pathophysio. So pathophysio is basically lungs are not getting enough blood, so that's why exchange is poor, which causes hypoxia and cyanosis. Which cyanosis? Central cyanosis, where you see the bluishness on the lips, tongue, face, that is called a central. And the blood cannot go to the lungs, so it accumulates in the systemic vessels, that is in the liver, GIT, legs, and that cause congestion and edema. So systemic congestion and edema, so that will occur. Now let me show you the systemic congestion and edema. Have a look. One second. Okay, let's see. So this diagram, if right heart fail, the blood will not go to the lungs. So where will the blood accumulate? It will accumulate in the right ventricle, right atria, also in the which vessels? Pulmonary veins, and ultimately in the legs. So now there is congestion, edema in the feet, and this causes the swelling, edema, all the changes. Okay, and JVP will increase because JVP show the right atria pressure. So that's why lungs are not getting blood, and that's why the right ventricle is showing the failure changes. Okay, so let's see the finding. First, there would be peripheral, also called as pedal edema, which is pitting edema. That is, first, it is due to gravity in the dependent part, and if you press against the hard bony part, there is a depression form, and the depression persists. It doesn't disappear immediately like a balloon. Press a balloon, leave, the balloon pops out. That's why a balloon is showing a phenomena of non-pitting. So that's why inflammatory edemas are mostly pitting or non-pitting. They are non-pitting. So I'll write here somewhere inflammatory edemas they are non-pitting. Good evening, Dr. Abhishek. They are non-pitting. Okay, so they are non-pitting in nature. So we have two types of edema, pitting and non-pitting. Which is non-pitting? It is inflammatory edema which is non-pitting. Okay, now non-inflammatory like heart failure or liver disease, kidney disease, they are pitting. Okay, then rise in JVP more than 15 centimeter. Okay, and there is also distended neck vein. Why? Because of blood accumulation in the right side. Then there is CVC liver, which give the nutmeg liver. So it is finding of CVC liver. So whenever there is a chronic venous congestion of the liver, you see the dilated vessels. Okay, and it give a red white appearance of supari. Nutmeg means supari, so it look like a supari chewing betel leaf. So that is called as your nutmeg appearance. Okay, plus the liver become very big in size, called as hepatomegaly. Liver is pulsating with every heartbeat because it's now congested, full of blood. That is giving you pulsatile liver. Plus we have the nutmeg liver. Okay, plus there is ascites, fluid in the peritoneal cavity. This fluid is not fixed. As you change the posture, it shifts. Like I go right side, left side, it will always be more in the dependent part. So dullness is in the lower dependent part. Also it causes a thrill. Thrill is a vibration which you can feel when you're striking the fluid on one side. Let me show you. So first, this is the findings. First, this is your jugular venous distension, this one. So this is the distended neck vein. This is fluid thrill. If you put the hand in the midline, okay, and then from other side, if you tap, the vibrations will go and hit the other hand. So this feeling of vibration on the other hand is called as the fluid thrill. And second question, this is shifting dullness. So like patient is lying supine, the dullness is in the dependent part, flanks. But if you make the patient go lateral, the dullness will go to the lower part and the upper part become resonant because it contains the air. So air causes more sound, that is vibration, and that is called as your tympanic note. Tympanic means it sound like a drum, like drum, dum, dum, dum. So it makes sound. This is called as your tympanic note, and this is dull note because fluid doesn't vibrate much with the striking, and that is the story. Next question. Okay. Also, there is a abdomino-jugular or hepato-jugular reflux. What is that? When you press, it's also called as reflux. So when you press the abdomen over the liver area, the pressure increases in the liver, push blood into the heart and increases the JVP. So your JVP will increase on pressing over the liver. So this is called as what? Our hepatojugular reflux. So remember, jugular and liver and pedal edema, they are findings of what? Of our right heart. So just give a summary. So right heart failure, jugular and pedal and ascites and hepato. बस इसी में आपका क्वेश्चन निकल जाता है. So jugular, pedal, ascites and our yes hepatic or hepato and our hepato. चल. Next is left heart failure. So what failure? Left heart failure. In left heart failure, there is a VFib. So left heart failure, there is ventricular fibrillation could be there. Then myocarditis, rheumatic fever, then hypertension, MI, infections, HOCM, or dilated cardiomyopathy. They all can cause left heart failure because the pumping is poor. Okay. So as the heart fail to pump the blood, what happens? The blood will not go to which area? It will not go to the body. So it causes shock, cardiogenic shock. This is heart failure. BP will decrease, but heart rate will be high. So heart rate is high. Why the heart rate is high? Obviously because of compensation and there's a decrease in cardiac output. Okay. Now clinical features. The cardiac shock feature is skin become cold and pale. Reason? Skin is not getting the blood. If skin is not getting the blood, what is going to happen? The skin will show what? It will give a cold, pale skin. Plus the pulse is very fast but very low volume, called as rapid thready pulse. So rapid thready pulse is there. What else is also there apart from that? Let's see. Also, kidney doesn't get the blood. As kidney doesn't get the blood, there's a fall in the GFR and there's the low urine output. Okay, oliguria is there and kidney can fail, called as pre-renal failure or azotemia. Okay. Then in case of LVA, what also occur? There's a fatigue, weakness, fainting, syncope. Why? Because of less blood supply to the body. Okay. Then there is DOE. What's DOE? Dyspnea on exertion. Now, what do you mean by that? The person become breathless, shortness of breath when he's doing some activity or even rest also. That is at rest. Okay. So that is dyspnea at rest or dyspnea on exertion is activity. Then there is, thank you very much, Dr. Yatin. Okay. There is a limitation to physical activity because of the poor pumping. You cannot do activity like before. Like you cannot run, you cannot climb the stair. This is called as limitation to physical activity. Then heart can show cardiomegaly because it's not pumping. So it can show cardiomegaly. Then there is S3 gallop rhythm, which is the loud S3. So loud S3 is there. It indicates systolic failure, which I discussed already. Systolic heart failure. Then blood accumulate in the lungs because not going out of the lungs because the left ventricle has failed. So cause pulmonary congestion and pulmonary edema. Let me show you. So this is the diagram for this. The lungs are unable to drain them out. So the blood will keep accumulating in the pulmonary vessels. So this increases the pulmonary capillary wedge pressure, which we discussed in physiology, and that causes filtration of fluid. And this causes the fluid to accumulate in our lungs. That causes pulmonary edema. Mainly which area? Base. So the base area which will get more congested and more edematous. Okay. Okay. Next, move to next point. That is our yes. There is an increased load on the right ventricle, so it can cause RVH, pulmonary hypertension, and later right ventricular failure. Now, pulmonary congestion is indicated by high pulmonary capillary wedge pressure. So that is very, very important. Okay. Yeah, no need to give GTs, okay, if you are not getting a good score. It just demotivate you. Better, yes, focus only on doing PYQs and the race session. That is more than sufficient. Don't waste time going for what? Useless stuff. So I'll advise you, avoid going for things which are not appropriate. Clear? So that is a story. Okay. I'm just checking. Next question. Don't take tension, okay? Just keep studying and give the exam. Chalo, let's continue. Now, the fluid as it leak into the lung interstitium, it causes the cardiogenic pulmonary edema. The hallmark is increased pulmonary capillary wedge. So remember, if there is a increased PCWP, this is our cardiogenic pulmonary edema. If there is a increase in the PC, then you say lungs involved due to heart failure. If there is normal PCWP, is non-cardiogenic. Chest X-ray will show bat wing appearance. This is the bat which I think was responsible for COVID-19. Someone ate that bat and caused COVID-19. So this is looking like a bat shape edema, bilateral, and it is having a wing-like projections. Then there's also curly B lines. I hope you can see this faint whitish lines. These ones. These are called as our curly B lines. Can you see them? I know they're not very well visible, but you pay attention, they are here. Okay. So called as curly B lines. Okay. Plus there is a cardiomegaly. It is more than how much? What is the ratio for cardiomegaly? I taught you last time. Yes, more than 0.5 CT ratio. Okay. So they are the signs of our heart failure. Now there is also orthopnea. What does that mean? Ortho means straight. So when the person lie down, he become dystonic. Why? Because the blood will shift from legs to the lungs and patient therefore sleep in position like this. This is how he sleep. Why is he sleeping like this? Because if he lies straight, he will be having problem in breathing because the lungs will get congested. So that is why they sleep in which position? Propped up position. Put pillows behind them. Okay. Then there is nocturnal cough and P and D. What is that? Patient wakes up with sudden severe breathlessness in the sleep. That is called as P and D. Now fluids in the lung create bubbling sound. That is called as crepitations. So bubbling sound, crepitation, and they have inspiratory crackles in the base of lung. So these sounds are heard in the base because the fluid is maximally there in this, plus RBC which come due to excessive, like congestion, the blood RBC can leak out, and these RBC create pink frothy sputum. So bubbles are there because of air and surfactant action which create the bubbling effect like the detergent. So what happens? Detergent create bubbles. Same way surfactant with fluid and air create bubbles. Plus red is because of the RBC. So red is RBC. Also there is inspiratory rails present. Okay, and this inspiratory rails are present. Okay, and what do? They are also going to show what? Pleural effusion. So they show pleural effusion in this particular case. So they show the pleural effusion. Okay. So summary, if there is JVP changes, hepatic changes, suspect right heart failure. If there is left heart failure, cardiac shock, pulmonary edema, orthopnea, PND, all will be there. Now, if a person has both right and the left heart, it's called as congestive heart failure. It has features of both. So what is features of both? Is called as CHF, and we use Framingham's criteria. So how to remember? If heart fail, person will die. So you will die due to heart failure, due to CHF. So that's why now your photo goes in a frame. So when will you become a part of frame? फ्रेम के अंदर हम कब आ जाते हैं जी? फ्रेमिंघम. सो हम कौन है? हम मर गए. तो हम किस में आ गए? फ्रेम के अंदर. सो फ्रेम इन हम. कब आते हैं? डेथ के बाद। और डेथ क्यों होती है? हार्ट फेलियर से। फ्रेमिंगम्स क्राइटेरिया इज ऑल्सो अ कोहॉर्ट स्टडी which is done for heart disease. Okay, MCQ, very 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 important and asked multiple times in the exam. Okay, chalo, let's see next. Okay, now what are the major features? So remember, it is two major. So the diagnosis, two major, one minor. Okay, two major, one minor. Now remember, what are the findings? So 2 JVP changes, hepatojugular reflux plus increased JVP, 2 sound S3 gallop and rail inspiratory, 2 pulmonary edema and PND orthopnea. Three changes. So edema, orthopnea, PND, and cardiomegaly and circulation time, it become more increased because of slow circulation. So circulation becomes slow, so it become more than 25 seconds. So let me teach you now here. So major PND, orthopnea, neck vein distension, inspiratory rails. Then there is cardiomegaly on radiography, acute pulmonary edema, S3 gallopedema, increased central venous pressure above 15 or 16 or more. Then circulation time increases to 25 seconds. Okay, sorry, means it slows down, so it become more. Then hepatojugular reflux is there, that is increased JVP, I told you, and weight loss more than 4.5 when you give the treatment. Why? Because you give diuretics which cause the clearing of edema. Now compensated versus uncompensated. Just remember, in a patient, good evening Dr. Mohit, kya baat hai? Okay, you pass, congratulations, my best wishes to you Dr. Mohit, and get a PG seat soon. Okay, chal. Now next question is compensated heart failure. What is the story? So cardiac output and BP are maintained in what range? In normal range. So they are maintained in the normal range, and there are very few sign and symptoms. What is there? Very few sign and symptoms are there in the person. Very few. I'm telling you treatment. Okay, Sagarika, it's coming soon. Okay, the treatment part will see very soon. Okay. Now next question. So if there are very few sign symptom and the BP is maintained, that is above 90/60, that is compensated. But if the BP decrease less than 90/60, that is called as our uncompensated heart failure. Okay, thank you very much Dr. Mohit. Okay, now next question. What is the mechanism? The mechanism is number one, sympathetic. So heart is the mechanism of compensation. It is increased sympathetic, that's why heart rate increase. So that's why increased heart rate at rest might be indicative of poor, yes, cardiac pumping. So that's why as the stroke volume decrease, to compensate, heart rate increase 100 plus 100. So a resting heart rate 100 should not be ignored, must be investigated. Okay, so that is the compensatory mechanism. Also it can lead to increased sweating. So that's why sometimes patient of heart failure, they say I sweat a lot, I don't know what's happening. Your heart is failing, that's why you're sweating a lot. Okay, so that is the simple concept. I hope so one day we open in Hyderabad again. Last time we opened, but again so many factors were there, we could not sustain in Hyderabad and we have to shut it down. So that's the problem. Next question. Ventricular remodeling occurs in our chronic heart failure. Now as there is a ventricular remodeling, it is causing a abnormal structure of the, yes, proteins and the contractile structure like actin myosin, which causes poor pumping. Now also person develop limitation to physical activity. Now what do you mean by that? The person has dyspnea on exertion. So whenever he will try to do any kind of exertion, he will have breathlessness. Okay, that is why we have 4 types of what classification of heart failure. It's called as NYHA classification. NYHA classification. Class 1 to 3, the patient is comfortable at rest, but there is a limitation to physical activity and dyspnea on exertion, but very few or no sign symptoms at rest. So rest is okay, that's why it's compensated. In class 4, it is at rest. Just 1 second. Okay, I'll just take my strepsils. 1 second. Okay. Let's continue. Okay. Now class 1. No sign, symptom, at rest and can do anything, no limitation, nothing. Normal. So what look just like a normal person? This. Only when you do echocardiography, you might get some finding. Class 2, there is a mild symptoms and slight limitation. So slight and mild is the word. So what is the case? Slight limitation, slight. In 3, there is a marked limitation and there is a problem in doing even less than ordinary activities. Remember, mild, slight, ordinary. Mild, slight, ordinary. What is marked and less than ordinary? It is class 3. Class 4 is at rest. So class 4 is at rest. So when is the problem? It is at rest. Now investigations, mainly history, clinical examination. Now if there is a rise in the ANP and BNP level, it is like ANP is atrial natriuretic peptide. If it increase, it causes sodium loss and reduce the congestion edema. So that's why it is very beneficial. So that's why we check the anti-pro-BNP level. So what we check? Anti-pro-BNP level is checked in the patient who are having heart failure. ये आपका PYQ है. What is checked? Anti-pro. Okay. Plus we can do cardio examination by echocardiography, echo. Okay. And yes, we can do galectin 3 or ST3, new marker. Galectin 3 and ST2. They are new markers of heart disease. New marker of heart failure. So echo is investigation of choice, but nowadays we can use MUGA. What is MUGA? Multi-gated acquisition scan. It is one of the best for wall motion. If ventricles are not able to work, then we can go for, yes, wall motion given by our MUGA. MUGA is for multi-gated acquisition. It's actually a radionucleotide study which give you the, yes, functioning of the heart. Now, I am good, Dr. Aman. I hope you are also doing good. Yeah. So let's continue. Okay. What is the goal? Goal is to reduce the burden and increase the efficiency. So goal kya hai? Number 1, decrease the load and increase the efficiency of pumping. Now, what we can give? ACE inhibitors are the drug of choice. They are the one which causes the decreased sodium, decreased volume, because they are blocking the angiotensin 2 aldosterone. So that's why they decrease the preload. They reduce the excess volume fluid. Also, they prevent the dynamic remodeling of the heart, because heart is now you are getting rid of the fluid. Excessive fluid causes stretching, distension of the heart. So that's why they are the best for, yes, mortality and morbidity reduction. For reducing mortality and increased longevity. Okay. And also beta blockers. So these two drugs are the most beneficial to increase longevity. But if you have to choose one, always go for ACI is superior to beta blocker. So both are very good, but if they have to choose one, like they give, what is better, beta blocker or ACI? I'll say go for ACI. Now, diuretics like loop diuretics, furosemide, torsemide, they are drug of choice of acute pulmonary edema. ये question कई बार आया. So what do you give in case of pulmonary edema? We give loop diuretics. What we give? Loop diuretics. Next question, vasodilators. So nitrate, CCB, they cause vasodilation, decrease the resistance and decrease afterload. So it's easier for heart to pump because of lower resistance. So that's why they improve the blood supply also and pumping. Beta blocker are very special. Why are they special? The beta blocker basically what they do? They decrease the heart rate. So now the heart has less oxygen demand and less work to do. So decrease the load. Which is the best drug? Carvedilol. So carvedilol and metoprolol are the most commonly used one. But remember, they have very good prognosis and very good outcome and increase in the lifespan of the patient. But important thing, they can be used in diastolic or chronic compensated heart failure. So what can be used in? It is used in diastolic, chronic and compensated heart failure. Contraindication of beta blocker, never use them in acute, systolic or decompensated heart failure. Why? Because beta receptors are for pumping also, beta 1. So as you block the beta 1, maybe pumping is poor. That's when systolic and acute or shock, never use. So in cardiogenic shock, don't use beta blocker. We rather use beta agonist like dobutamine or adrenaline, noradrenaline, but we never use what drugs? The drug which is decreasing the contraction, MCQ. So what is avoided? Avoid it in this case. Are you clear? Chal. Next is we see inotropic agents. Inotropes are the main drug which we are using in our systolic heart failure and also cardiogenic shock. Like they improve the pumping. So main drug which was earlier the drug of choice were cardiac glycosides. So they are digoxin, digitoxin. They inhibit which pump? Sodium potassium pump, which increase the sodium, and sodium that exchange with calcium. But remember, digoxin is one of the most toxic drug, need therapeutic drug monitoring. So that is why it's very, very dangerous. Okay. And heart block, arrhythmia are very common. And what are the most common arrhythmia? It is ventricular bigeminy, ST, depression, reverse tick sign. I discussed that already in ECG, and U wave, also T inversion. They all are findings of our digoxin. And most specific arrhythmia which is seen by digoxin is NPAT. What is NPAT? Non-paroxysmal atrial tachycardia with AV block. Okay. Drug of choice, we have to stop the agent and we can give digibind, which is immunoglobulin which bind and help in, yes, removing it from the body. So that is the case. PDF is already there in the description. Click it, you will find it. Okay, clear? So click the description, Google Drive, click that, file is there. Okay. So how to solve the paper? I'll take a session for that later. Don't have to worry. Okay. So I'll take the session later for that. Okay. Chalo. Next question. If there is heart failure with shock or neurogenic or cardiac shock, drug of choice is without doubt noradrenaline is the drug of choice for neurogenic and cardiogenic shock. Remember, so what do you give? Answer is we always go for noradrenaline. Then we have new drug like milrinone. So milrinone, what does? Milrinone, it inhibit PD, increase cyclic AMP, which increase calcium and contractility. So that's why it's one of the new inotropic agents. Also some new drugs like sacubitril, omapatrilat. It was asked in the recent exam last year, NEET PG. This question was there. How does omapatrilat act? It inhibit both NEP and inhibit ACE also. So what is a ACE inhibitor plus NEP? It is our which drug? Omapatrilat. So it inhibit both. Okay, omapatrilat. Okay. क्या बात है डॉक्टर हाराकिरी, congratulations, get PG seat and do your best. Okay, now surgical treatment. We can help the ventricle pump by putting a ventricular assist device. What the ventricular assisting device, the assist device do? So ventricular assisting device, basically they are an artificial pump. It collect the blood from the ventricle and give it to aorta. So that's why it's helping some of the pumping by giving blood from ventricle to the aorta. This is called as ventricular assisting device. So ventricular assisting device. Finally, we can go for his heart transplant. So last treatment is heart transplant. Now let's say JVP. What is JVP? Jugular venous pressure. It show basically what changes? Right atria changes. So when the right atria contract, we get the A wave. Right ventricle contract, we get the C wave. When atria relax, I told you X is relaxed. And when atria get filled with blood, so A, X, C, X dash, V, Y. This is JVP. And when the atria empty, there is a Y descent. These things I have discussed already in which topic? We have discussed them already in the topic of physiology also. Okay. So now comes the question. What is the story? So I'll write it here. So first is A wave is absent if the atria fail to contract. What is that? That is called as atrial fibrillation. So in atrial fibrillation, A wave is absent. So A wave is absent. Then if there's a very big giant A wave, very big giant A wave, it is seen when the tricuspid valve is narrow, like tricuspid stenosis. So blood cannot go to right ventricle, it goes to the jugular vein. So again, it causes a big A wave. Then cannon A wave is actually a double A wave like this. This is called as cannon. So this one A, this is a very big giant A. It is because of AV block. So there's a complete AV block. When ventricle contract, the aortic valve is closed. So all the blood goes back to this. So that's why one A wave is normal, other is very big. Why? Because of, yes, complete AV block. So complete AV block give you double A wave or cannon A wave. Cannon A wave. Okay. Now V wave become big if there's a regurgitation. So if ventricle contract and the blood goes back to the atria, that is tricuspid is incompetent, this causes more blood in the atria, so more filling of the atria. What is the filling wave of atria? V wave. So V wave become very big. So V wave become very big, and that is causing the large V. And this V can merge with the C, causing CV wave. So that's why when they merge with the C, it causes CV wave. So remember, large V and CV is seen in TR. Lastly, there is constrictive pericarditis and tamponade, CT. So remember, CP CT story is very important. In CP, X is prominent, Y is also prominent, both prominent. Remember. So in Connaught Place, both are present. So Connaught Place, people go for shopping also and sightseeing. दोनों मिलते हैं वहां पे, X भी मिलेगा Y भी. तो आपको अपनी X भी मिल जाएगी और आपका Y भी मिल जाएगा, Y. Whereas tamponade is cut. किसने काटा? X ने. So X is there and don't ask why. So don't ask why. So why X cut you. So remember, cut CT is only X, Y absent. Only X, no Y. So अगर X दिख रहा है, no Y, it is your tamponade. If X, Y both are present, it is constrictive pericarditis. Let me revise you and ask you questions for you. Let's hope we are able to get them for exam also. Let's revise. A is absent. Diagnosis. A absent. A is absent. Give me diagnosis. Anyone? 100% exam questions will come from JVP. Tell me. Tell me. Yes, AFib. So AFib, okay. Giant V and CV. Giant V and CV. Give the answer. Giant V and CV. Yes. TS. TS is the case. So giant V and CV is TS. Okay. Where will you see X and Y both? X और Y दोनों आएगा. Where will see X and Y both? Both. ये TR हुआ ना. चलो बताओ. X and R both. constrictive pericarditis. X present, Y absent. What is that? This is CT. This is in CT. Okay. Clear? Chalo. Next question. Where we'll see a giant A wave. Giant A. Giant A wave. Giant A. Yes, it is seen in TS, tricuspid stenosis, and canon A. Canon A. Canon A. We'll see canon A. Yes, it is seen in our which condition? AV block. Third degree complete AV block. Okay. So let's go back. So this is all the JVPs. This is CV. See, X is very small. CV wave. This is the CV wave. This is very prominent X, but Y is not prominent. This is A, canon. Now, very important 100% exam question. Always ask in the exam. CT. What is CT? Cardiac tamponade. So CT is cardiac tamponade. It's a medical emergency. It's a medical emergency. There's a massive accumulation of fluid around the heart in pericardium. Could be blood. Okay, could be blood. Example RTA. So if it's a road traffic accident, it could be blood. Now this causes collapse of our which ventricle? Right ventricle. That's why there's a poor filling. You can't fill, so can't pump. So both are poor, and there's a history of trauma. RTA, so maybe blood. So it might bleed. RTA might bleed or have blood coming into pericardium. So what are the changes? So therefore there is less pumping, less filling, and the veins cannot give blood. So that is why the heart is not pumping. So veins get dilated, distended. So JVP will increase. So what increases? JVP increase. What the mnemonic is? Backstride. What is backstride? BP is low, less than 90/60. The neck vein get distended, JVP increase, and there's a muffled or absent heart sound. Okay, why? Because pumping is not there, plus the fluid is covering the heart, so sounds are not. So absent heart sound, distension of neck vein, and low BP is called as backstride. Now diagnosis, you can see X is there, but Y is absent. Why? The ventricle has collapsed, so will not fill. And remember, X and Y. What is Y occur because of the ventricular filling and atria empty. Now atria cannot empty, so Y will be absent. So that's why if you see Y absent but X is prominent, it is our CT. Also in ECG, there is a change in the amplitude of the R wave with every beat, big, small, big, small. This is called as electrical alternance. See? So have a look. The R wave is this much, then this much, this much. So the size is not fixed. It keeps changing. This is called as electrical alternance. So remember, changing R wave plus prominent X, absent Y, and person not able to pump the blood. Shock is there, heart sound not heard, muffled, plus there is also neck vein distension. This is the echo. You can see in the echo, this is the right ventricle compressed by the fluid. So the fluid which is compressing it, okay, and In effusion, we see X-ray में money bag appearance. क्या बात है? You are also having tea. Actually, tea is good for speaking and teaching. As a kid, I hated tea. I will not drink tea. But then I became faculty and I started drinking tea. And then I realized, okay, tea can help you stay awake. Otherwise, I hate tea. I don't even like anything bitter. So I don't love to drink bitter things or eat bitter thing. I only eat salad. I love salad. I don't know why. Maybe I'm a vegetarian by genetic factor. I'm a cow. I can chew salad all day. Cucumbers or what do you say? Anything, okay? Avocado or what? Broccoli, anything, okay? Onion. For me, best is salad. So that's, I think, one thing. This genetically there. Okay. Pulsus paradoxus, very important, is a decreased BP on inspiration. That is called pulsus paradoxus. Okay. And finally, treatment is the emergency. What is the emergency treatment? We do ultrasound guided pericardiocentesis. In case you cannot do ultrasound guided, you can do sub-xiphoid approach. In case there is no option of ultrasound available. So in case no ultrasound possible. Okay. So we insert the needle in the pericardial sac and we drain the fluid out. What is it called as? It is called as our pericardiocentesis. Later we create an opening and this opening help us in drain the fluid out, and that's we can do pericardiotomy to slit. Now interesting question, summary. CT. So remember, CT is cut gaya. So who cut your relationship? Who cut you? Your ex. Ex ne काट दिया. So remember, don't ask why. Do you want to know why? Do you want to know why? Tell me yes or no. No, because it will hurt your ego. So if your ex tell you, I left you because of dash, dash, dash. Khatam. Because he or she will tell you things which are very humiliating, very insulting. Maybe something about your body, something about your behavior, maybe something about other people. So that is why never ever ask why. Okay, so don't ask why. So X is present, Y absent. So X is present, but Y is absent. So remember, when someone cut you from their life, don't ask why. Now you should go back to your previous life. Okay, go back. So क्या बोलती है? भाग यहाँ से. Go back. So backstride. So what is back? Is backstride. And what is the person is in shock. हैं मेरा कट गया. So he or she is in shock. No sound is coming from the mouth. So person is in shock. No sounds are there. And he's full of pain, regret inside. He's full. So that's why veins are full of blood, distended. And with the treatment, take the fluid out. So this person, treatment क्या? पानी निकालना है इसका, पानी. So remove the fluid out. क्या करना है इसका? पानी निकालना है. Pericardiocentesis. तो हो गया निमोनिक क्लियर? So किसने काटा? X ने. क्यों काटा? पता नहीं. No why. Then go back to your previous life. You are in shock while you're going back. So when you're going back, what do you see? You are shocked and you ask your friend, what happened? You say. And he's filled with pain. So that is filled with pain. Chalo. Now we'll discuss CP. What is CP? Constrictive pericarditis. So what is CP is? CP is our constrictive pericarditis. So are you clear? So that is the case. So constrictive pericarditis. Constrictive pericarditis. Okay. Next question. So what happens here? There is a very thick calcified hard pericardium, very stiff. What is this stiff pericardium doing? It is not letting the ventricle expand, and this. That's why it causes a diastolic dysfunction and failure. Okay. Mostly it is seen after TB pericarditis. So after tubercular pericarditis, there's a fibrosis and calcification of pericardium. It make it not stretchable. Okay. Now X-ray, you can see egg in cup appearance. So it look like a white color. Can you see this? So this is your egg in a cup appearance. So egg in a cup appearance. Okay. Investigation, first is pericardial knock. What is that? When the heart is beating, the ventricle hit the hard pericardium making sound. This sound is called as knocking, knock sound. Then X-ray, I told you, angina cup and JVP both are prominent. Both X and Y are prominent, and also very important, Kussmaul sign is positive, 100 times asked in the exam. Now what is Kussmaul sign? It's a increased JVP when you do inspiration. So increased JVP on inspiration is Kussmaul sign. Okay. Now it is absent in the tamponade because the ventricles are collapsed there. So that's why there is no scope of the blood coming and increasing the JVP. So that's why absent in tamponade but present in CP and restrictive cardiomyopathy. Okay. 100 times asked question. And pulses, paradoxes can be seen, might not be seen, but what is seen? Kussmaul and XY. Kussmaul XY. Treatment is इसका भी काटना है pericardium, so we can remove and avoid exertion and can use beta blockers. So can use beta blockers. So summary, Kusum. Kusum is a girl. She is a girl. She went to mall. Where? In Connaught Place. CP. Connaught Place, very famous in Delhi. Most couples go there for, yes. So Connaught Place. So कहाँ गई ये? CP में. With boy. किसके साथ गई? With boy. X and Y. So boy is X and Y. Okay. And they had the egg in breakfast. Breakfast? Okay. जो भी है. And cup of tea. So remember, egg in cup. So क्या है? Egg in cup. Egg in cup. So Kussmaul किस में दिखता है? CP में. Kussmaul CP में with her boyfriend. तो X and Y क्या होता है? Boy, X is girl. So X and Y. X and Y. I can't see the chat. I don't know what's happening. Today my chat I cannot see at all. So chat is not visible. So आज क्या है? Chat में बड़ी दिक्कत आ रही है. So I hope it will not be a problem. One second. I'm just checking my chat. Are you people able to see the chat? Because I'm not able to see the chat today. Okay. Sometimes keep typing so that I can listen. Sometimes difficult to listen. Okay. Now we'll discuss auscultation and valve area. So let's discuss. First is valve area. MV, TV, PV, AV. MV, TV, PV, AV. 4 valves are there. All are. Now I can see the chat. Thank you. Now all are on the left side. Only aortic valve is on the right side. Second, all are in intercostal space near sternal border, except the mitral valve which is in mid clavicular line. All other are near sternal border. Can you see? So all the valves are very close to the sternum. Only mitral valve is in mid clavicular line. Otherwise all are where? They are in the sternal border. Next question. The second intercostal space contain the aortic valve on the right side, pulmonary on the left side. Third, so Arab is 3 letter, Arab, ERB. So Arb's point is near the third intercostal left side. TV has 4 side, so tricuspid valve has 4, and mitral valve M is 5. So M क्या है आपका? 5th intercostal space. So M के कितने side होते हैं? देखो M कितना easy हो गया देखो. M has how many points of touch? 1, 2, 3, 4, 5. So 1. So M has how many sides? Yeah, points, touches. So how many points? It has 5 points. So mitral valve is in 5th intercostal. Yes. Apartment क्या बात है? So it is our, yes. Yes, it is in the mid clavicular line, 5th inter. It is also called as apex beat. So where is the apex beat? Same location, 5th intercostal, mid clavicular line. So this is the valves of the heart. Okay. Now next is S1. So S1 is 25 to 45 hertz. It is due to closure of which valve? MV and TV. So whenever MV, TV close, whenever what closes? MV and TV close. Clear? What is the story? So it causes our S1 sound and it indicate the start of the systole. So remember S1, S2, S2, S1. ये हमने फिजियो में भी किया था. S1, S2 is systole and S2, S1 is diastole. And S2 के दो पार्ट होते हैं, A2, P2, aortic and pulmonary. So ये आपका summary है. So what is systole? S1, S2. So what start the systole? So systole start with what? Systole start with our closure of mitral and tricuspid valve. So which valve? Mitral and tricuspid valve. The systole will start. And remember, in case the MVTV doesn't close, they are incompetent, they don't close, the blood regurgitate from ventricle to atria. This is called as MR and TR. If they are incompetent, and the blood will go to the atria in whole cycle of the systole. That's why it causes the pansystolic murmur. Which murmur? Pansystolic. MCQ. So MR and TR, what is the murmur? Pansystolic. How to remember? PSM. PSM is a subject. PSM is a subject in which you study mortality rate. So PSM में MR आता है ना, तो याद कर लो MR का मर्मर क्या है? PSM. So IMR, PMR, PMNR. Which subject you study about mortality rate? Answer is PSM. So PSM का मर्मर MR है. PSM का मर्मर MR है. Also in MR and TR, the valve doesn't close properly. So that's why soft S1, because the valve is incompetent. And finally, MVTV open in the diastole or systole. They open in the diastole and cause a sound that is called as the opening snap. So it's called as the opening snap. Okay. Chal. Now second heart sound is S2. S2, yeah, PSM पढ़ के मर गया. ये भी याद करते तो PSM पढ़ा मर गया. PSM मर. Now second heart sound is 50 hertz. It is due to closure of what? It is due to closure of AV and PV. So once there is a closure of AV, PV at the end of systole and the start of diastole, it is your S2 sound. So what sound? S2 sound. Now if AV, PV doesn't close in diastole, the blood can regurgitate from where? From aorta to left ventricle, and that cause a early diastolic murmur. So AR, aortic regurgitation cause a early diastolic murmur. Don't forget this, it cause a early diastolic murmur. Also in AR-PR, there is a soft S2, like in MR-TR, soft S1, here we get a soft S2. Second, S2 is due to closure of A2 and P2. What is A2? Aortic valve. P2 is pulmonary valve. Okay, so it is S2. And opening of the AV-PV causes the ejection click. So remember, opening पे click आता है, closure पे A2, P2, S2 आएगा. So S2 has two parts, A2 before P2. And why A2 come first? Because the pressure is more in the case. So that's why A2 appear before P2. So A2 appear before P2. Okay. Yes, Roy, this point we have discussed already. Okay. Because electrical changes occur before the mechanical change. But clinically, we are just relying on the sound to know the cycle. Okay. So that is why electromechanical systole is QS2. Okay. So that is the case. We don't start from S1. We start from the Q wave. Okay. That is the case. Chalo. Next question. What are the causes of split? So let's discuss splitting of heart sounds. We are discussing, yes, splitting of S2. So first is physiological splitting. Now what do you mean by physiological splitting? So physiological splitting occur in inspiration. Why? Because when we inspire, more blood goes to our heart and the lungs. So lungs are now getting more blood. Why? Because you're inspiring. So they pull blood into the lungs. How? Example, when we inspire, more blood goes to the heart, right side, and it will give to the lungs. So lungs are getting more blood. So now the right ventricle need more time to pump the blood. So that is why gap is increased in case of inspiration. This is called as physiological split. Let me show you. See, this normal person. So where do you see gap is more? You can see the gap is more in inspiration. Why? Because more pulmonary blood flow. So increase time taken by right ventricle. So if the right ventricle take more time, then we are going to see, obviously what? We are going to see the P2 delayed. So P2 will be delayed. So P2 will be delayed in this particular case. Clear? So is it clear to you? Let's continue. Okay. Now we'll discuss pathological splitting. So let's see pathological splitting. So first question is we have is, okay, first, if there's a gap increase between A2 and P2, this is pathological splittings. Like example, first, if P2 come before A2, it is called as paradoxical or reverse split. Normally what should come first? A2 then P2. If P2 come before, that means it's a left heart problem like left bundle branch block or aortic stenosis. In this case, yes, hello Dr. Birchkesh, okay. So that is called as the reverse split. Reason, if there's a blockade of left ventricle, it'll take more time. So pulmonary valve will close first. So that cause P2, A2. Let me show you. This is paradoxical split. P2 come before E2. So what happens? Left ventricle contract late and that's why it take more time. Hence P2 come before A2. Example, left bundle branch block or some aortic problem. So this causes the, yes, splitting where P2 come before the A2. So P2 come before the A2. Okay. Then there are two kind of splitting. One is our variable split and wide split. This I discussed already, if you remember, in the topic of pediatrics. Remember, as कैसी होती है? As मैंने निमोनिक भी दिया था. As कैसी होती है? Wide भी होती है और split भी होती है. तो क्या था निमोनिक इसका? As is wide and split. तो as बड़ी भी होती है, लोगों की बहुत बड़ी as होती है, देख रहे हो? And it is very wide also and split in the middle. And it is fixed on the chair. So when they are sitting, they don't ऐसे shake. तो वो कुछ और होता है shaking. तो याद करना, ASD is wide fixed split. ASD is wide fixed split. We discussed that in pediatrics. Now, if it's variable, it is a Mr. Variable. So if you get a variable split, that is inspiration, expiration, gap changes, it is called as variable. If the gap remains same in inspiration, expiration, the gap is same, it is called as our ASD. So ASD, wide split but fixed. Variable is VSD and MR. And they have which murmur? Pan-systolic murmur. So remember, pan-systolic murmur and variable split is MR and VSD. Sure. Now we'll discuss S3. Now what is the S3? S3 is due to early ventricular filling. So which filling? Early ventricular filling, when both MVTV open and the blood fall into the ventricle. Pathological S3 is systolic heart failure, gallop rhythm. Physiologically also S3 can be heard, especially athletes who have the hypertrophy, pregnancy or middle age because of hardened left ventricle. S4 is never physiological, is always pathological. So what is a pathological sound? S4 is a pathological sound. What is it due to? It is due to late ventricular filling. So it's due to what? Late ventricular filling, and it appear just before S1. So it appear just before the S1 with sound S4 sound. So with sound S4 sound. Physiologically not heard because frequency is less than 20, which is below the range of hearing. So pathologically it is heard in diastolic heart failure or hypertrophy. Also PSA. What is PSA? Pre-systolic accentuation in mitral stenosis. So MS में सुनाई देती है हमें ये because of narrow valve. So sound become turbulent when the ventricle is getting late filling due to atrial contraction. So it's due to atrial contraction. तभी आपको फिजियो आनी चाहिए मेडिसिन पढ़ने से पहले. इफ यू डोंट नो फिजियो and you want to learn medicine, it's a very big mistake. You will fail to learn it because they are all interrelated. So summary, I'll discuss. If there's a mitral stenosis and mitral regurgitation and tricuspid, MRTR, we get a pan systolic murmur, soft S1 and variable split. What split? Variable split. So if you get a variable split S2, soft S1, pan systolic murmur PSM, diagnosis is MRTR. If it's a mitral stenosis, or tricuspid stenosis, then it is opening snap plus mid diastolic murmur and pre-systolic accentuation in the late diastole. That is in late diastole. I discussed it already. Middle will be murmur, late will be PSA. If there is a aortic stenosis, should be aortic, not atrial. Please correct it. If there is a aortic stenosis or aortic regurgitation, in stenosis there is the ejection click and MSM, mid systolic murmur. So what murmur? Mid. So mnemonic is आस पास देखो और मत शर्माओ और फोटो खींच लो. Click the photo. MSM. So what is MSM? MSM is mid systolic murmur. Mid systolic murmur. And aortic regurgitation and our pulmonary regurgitation, it give you what? Early diastolic murmur. Sometime it could be mid diastolic also. If mid diastolic, it's called as, if MDM, called as Austin Flint. Austin Flint. So if it's mid diastolic, then it is called as Austin Flint murmur. So now let me give you a summary with a diagram photo. Is very important. Let's see. This photo, please remember, it came in last year NEET PG also. Every year this photo or the question come. If you really want to do well in the exam, pass the exam and get good score, you should be clear. So S1, S2 is systole, S2, S1 is diastole. If a murmur come from S1 to S2, it is called as pan systolic murmur. So what is PSM? PSM is seen in which disease? PSM. Yes, MR and TR. If there is a ejection click and mid systolic murmur which look like a diamond, so it's diamond shape. This is our which disease? This is our aortic stenosis, AS. If pan systolic murmur PSM, so PSM is basically MRTR. If there is a early diastolic murmur EDM, it is AR, aortic re. And if there is a opening snap plus MDM plus a pre-systolic accentuation, this is PSA, PASA. तो ये तीनों अगर आ गए OS, MDM, PASA, ये है mitral stenosis. So this give you all the murmur, 100% exam question. So remember, PSM is MRTR, then ejection click MSM, ejection click MSM. So ejection click MSM. If early diastolic, it is AR. If mid diastolic with PSA and opening snap, this is your mitral stenosis. Mitral stenosis. Okay. So remember the summary. In valvular stenosis, either it's a stenosis or incompetence which cause the regurgitation. Investigation of choice is echo. Always it is echo, which is best. Then congenital is since birth, which I discussed already in pediatrics class. Old age is mainly degenerative changes, and children or India is infection. Most common is rheumatic fever or rheumatic heart disease. Now remember, mostly asymptomatic. So avoid exertion. That's the main thing. If symptomatic, we go for valve replacement, which could be there, or repair of the valve. So valvuloplasty is repair, or then we can go for replacement. That is the symptomatic or severe cases. Clear? Fine. So that is the story. Okay. So we don't have to see this. Remember some summary point which I'll give you. summary point I am giving it. Just skip this part. We'll go to summary point because this we have discussed already. Okay. So remember, I write here the summary. So remember first, if there is AS there is SAD and MS से, बस इतना याद कर लो, SAD और MS से. What is SAD? Syncope, angina and dyspnea. So if there is syncope, angina, dyspnea, it is our aortic stenosis. तो याद करना क्या है ये aortic, और मर्मर क्या है इसका? Mid systolic murmur and ejection click, EC. So if you get the feature of syncope, angina, dyspnea, why? Because aorta is narrow, aortic outlet, that's why less blood is going. So it causes syncope, angina, dyspnea. Syncope, angina, dyspnea. Murmur is mid systolic murmur, MSM, and also ejection click. ये हो गया. AR में क्या होता है? In AR there is so many signs. So AR shows what? It shows EDM, MDM, and signs. And lots of signs are there. अगर बहुत सारे signs आ रहे हैं ना, वो AR है. Signs आ रहे हैं तो AR है. Let me show you the signs. What are the signs? 100% exam question. So I'm showing you the signs of AR. So AR में क्या होता है? Ventricle is getting back the blood from the aorta. So the blood in the ventricle make it very big and huge. See, so ventricle become very big in size. That is your aortic regurgitation. So it eject lots of blood in the aorta. This too much blood ejected into the aorta create what? Signs of AR. What are the signs of AR? Let's discuss. First, the pulse is very big but sustain. No, it doesn't sustain. That is called as water hammer or collapsing pulse. Then there is dancing of carotids, carotid artery. So this dancing of carotid artery is called as what? It is called as dancing carotids. It is called as Corrigan sign. Corrigan. Then there is a nodding of the head with heart beat. This is called as de-Musset sign. So head is not stable. It keep moving with every heartbeat, called as the de-Musset sign. Then there is also capillary pulsation. So here in the nail bed you can see the alternate red white color because of pulsation, called as Quincke sign. Then finally the uvula can also pulsate, called as Mueller sign. Okay, क्या बात है, very thank you doctor. Okay, I hope it will be beneficial again. Then Traube sign. What's Traube sign? This pistol shot heard over femoral artery is called as Traube sign. So Traube sign, pistol shot, as boom, dishum, dishum, ऐसे. So very sharp noise is there. That is called as. Plus there is also high BP difference between our, yes, our which thing? It is our between upper and lower limb. This is called as hill. तो कैसे याद करोगे? हिल कैसे होती है? Up and down. So up and down BP difference. Up and down BP difference is there. So up and down. Okay, चलो ये हो गया आपके ट्रीटमेंट. सबका मैंने बता दिया ट्रीटमेंट क्या है. और याद करना, if a young female has acute panic attack, it is most likely MVP. So एक राइट यहाँ पे समरी में young female, ये हो गया हमारा यहाँ पे, एंड यहाँ लिख लो young female acute panic attack and pansystolic murmur, PSM. Suspect MVP, mitral valve prolapse, which causes mitral regurgitation. So it's a mitral valve prolapse. Are you clear? So mitral valve prolapse. Okay. Let's move. So this we have discussed in summary. So no need to do them because time नहीं है हमारे पास. वरना I would have discussed it detail. See, most common cause is always rheumatic fever, or it could be, yes, other degenerative, autoimmune, SLE. So many are there. So I'm not doing it. Now come to rheumatic fever. Now, what is rheumatic fever or rheumatic heart disease? So it is actually an autoimmune disease, type 2 hypersensitivity. There are autoantibodies. What is the summary? One question always will come from rheumatic fever. If you have not done rheumatic fever, request you, please do rheumatic fever. So first, there is pharyngeal infection or sore throat caused by what? Group A streptococcus, and there's a very high ASO titer. What is ASO? Anti-streptolysin O. So anti-streptolysin O. Then antibody are formed against the M protein. Which protein? M protein of streptococcus, which cross react with the body tissues, okay, and damage mostly joints. That's why it's called as rheumatic. So joint, heart, skin, and other organ. Then it's a type 2. Female affected more than male. So remember, it's a very important point. What is affected more? Male, female. Obviously, female are affected more. Age group is young children, 5 to 15 years. Primary attack rate is low, but secondary is very high. That is why prophylaxis are a must. We need to give prophylaxis, otherwise there could be another infection. And remember, second time the antibodies are more and cause more damage. It's just like erythroblastosis foetalis. What happens in RH incompatibility? First pregnancy is okay, but second pregnancy, it will be a very severe immune response, and that is the same thing here. Now, diagnosis is by revised Jones criteria. So what criteria? Revised Jones criteria, which is two major or one major plus this. तो उसको मैं थोड़ा ठीक कर रहा हूँ. Two major or one major plus two minor. So that is the criteria. Either go for two major or one major and two minor. Now, major are Jones. J for joints. So joints show migratory polyarthritis, inflammation of the joints. Then carditis. All layers are affected, myocardium, endocardium. Then nodules, hard subcutaneous nodules with a central, this area clearing is the erythema marginatum. Then there is hard nodules. So these are the nodules, subcutaneous near the extensor surface. This is the case. Then we have the E. E is for erythema marginatum. It is basically plaques with a central clearing. So remember, this is called as erythema marginatum. And last is involuntary dancing movement called as Sydenham chorea. C. So chorea is last. Okay. So what is Jones? J for joints. Then O is carditis, heart. N is nodule. E is erythema. S is Sydenham chorea. What is S is? Sydenham chorea. So S is our Sydenham chorea. So what is the S is? S is Sydenham chorea is our S. So are you clear? Chalo. Now let's discuss. Most common is our joints and least common is our which one? It is erythema marginal, is least common. So least common finding is erythema. It is on the trunk. Can you see? So it look like क्या बोलूं मैं आपका, red circles with central area empty. So this is the red circles. Look like white mark as if someone has bitten the chest of the person. Now let's see minor. Minor are all R. Minor is ra 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 ra. Minor is ra. Fever, PR, CR, and ESR and arthralgia R. All R's. See, remember, joint pain is minor, joint inflammation is major. So minor and major. So क्या है criteria? Major and minor is our main criteria for diagnosis. Are you clear? Fine. So these are our criteria for diagnosis. Okay. So is it clear now? So that is our main funda or the main story that we will be discussing or seeing in this particular case. Okay. Chalo. Next is you get two major or one major plus two minor. So one major plus two minor is the funda. So one major plus two minor. Okay. Now we'll discuss carditis. So what we are discussing? Carditis. So what is the story about carditis is? So first and the foremost thing about the carditis is it could be pericarditis where chest pain is there because pericardium is pain sensitive, ST elevation, concave one, and pericardial rub. So these are the features that we are seeing in the case of pericarditis. Okay. Treatment is steroids and NSAIDs. So the treatment, steroids and NSAIDs are the treatment will be giving to the patient. So क्या देना है इसे? Steroids and NSAIDs. So steroid and NSAIDs are to be given. So clear now? So that is the treatment here. Next question. Right? Myocarditis. It causes systolic failure because of inflammation of the heart, and as heart is failed or heart is in inflammation, it is unable to pump. So that's why there is a finding of our which thing? Yes, congestive heart failure S3 gallop. Treatment is inotropic agents. Then come endocarditis, which mainly affect the valves. Most common is mitral valve, then aortic valve, then aortic valve, and tricuspid and pulmonary valve. So the order, mitochondria make ATP. So mitochondria ATP, MATP is the mnemonic, MATP. So MATP. So the most common mitral, least common is pulmonary, least common is pulmonary. Now remember acute rheumatic fever. First there is a what? There is a mitral regurgitation. Then there's a healing and calcification which cause stenosis. So that's why most common valvular lesion is overall mitral stenosis, but that is seen afterward. What is in acute? Acute is MR and overall is mitral stenosis. And the murmur of MS is caricum, which is a mid diastolic murmur. So remember very simple mnemonic. Who come first? Mr. So Mr. come first and bring the Miss, wife, Miss, and then Miss has very long hair. So Miss ke lambe baal, and what does the Miss use? So Miss use a comb to comb her hair. So Miss carry comb, Miss carry comb. So इसका mnemonic हो गया Mr. आया, Miss लाया, Miss के लंबे बाल, so she carry a comb. So that's why carry combs is the murmur. So the murmur is carry combs is the murmur. So it's the carry combs murmur. Okay. Chal. Pathophysio. In pathophysio, there is a rheumatic granuloma, also called as Ashkoff body. So this is the rheumatic granuloma or Ashkoff body. Main hallmark is which necrosis? Fibrinoid necrosis, where collagen fibers get deposited. So this is called as our fibrinoid necrosis. So which necrosis? Fibrinoid necrosis. Also there is infiltration by WBC. So what is taking place here? Infiltration by WBC. What does it create? It creates caterpillar cells. So what cells? Caterpillar cells. So caterpillar cells. So these are the caterpillar cells, which are actually also called as Anitschkow cells. Anitschkow cell is actually macrophages which show or look like a caterpillar. Can you see them? So it give a caterpillar like appearance. Okay, color is not green obviously, but caterpillar, Anitschkow cell. Okay. Now very important, there is also vegetations along the line of closure of the valve, and also we see McCollum's patches. Okay, so these are all the findings. Now treatment, very special. Treatment is we give benzathin penicillin. ये क्वेश्चन 1000 बार आया एग्जाम में. What is the treatment? Benzathin penicillin. Okay. Now, what are the dose in adult? 1.2 million unit. Children 0.6. If you want to give oral, we can give oral penicillin V 250 mg 2 times a day. Also, we can add steroid to decrease the inflammation. If allergic to penicillin, we can use the sulfa drugs. What we can use? We can use our which drugs? Sulfa drugs can be used in this case. Okay, if allergic to this. Okay, chalo. Now prophylaxis. What is prophylaxis? It is given to prevent the next infection. So we're giving antibiotics even before the next infection. Dose 1.2 million unit every 3 or 4 weeks. India we follow 4 weeks mostly. Foreign country recommend 3 weeks. Okay, so that's why what we are giving again, benzathine penicillin IM 1.2 million adult, child is half. Point 6. And if there is no cardiac involvement, it is for 5 years after attack. So how many years? 5 years after the attack, or 21 years. Kitna age? 21 year old. What old? 21 year old. Okay, and 18 years. Okay, some books say up to 18. So remember, always go for longer period. If there's a residual or cardiac lesion, then 10 years after attack, or till 40 years, or till 40 years. Always go for the higher duration. So higher duration is chosen. Okay, example, this is the vegetations. Now see, example, if age is 10 year and no cardiac lesion, what is 10 plus 5? 15, and 21 years old. What is old? 21 is longer, we go for 21. Okay, second scenario, age is 20 year, no cardiac involvement, then 20 plus 5 is 25, 21 year old. So what are you going to select? 21 year old or 25? Obviously we are going to go for our yes, 20 plus 5, 25, or 21 year old. Okay, yeah. So remember the rule. What is the rule? Let's do a question and check how much you understood. Should I do the question? Okay, a 15-year-old he got rheumatic fever but no cardiac involvement. So only had problem, let's say he had increased ESR, CRP, antibody, ASO was there, but cardiac involvement was not there. So prophylaxis for option दे रहा हूं, first prophylaxis for 20 years or 21 years or 15 year, 5 year, what? How solve करते हैं? 15 year old, so no cardiac, so we'll go for either 5 or 21, plus 5 or 21. So let's solve. 15 plus 5 is 20, and till 21. So obviously we'll go for 21 years. The answer is 21. We'll give for 21 years of age. Okay, till is 21 year old. Second question, a 28-year female has rheumatic fever with valvular lesion. तो उसकी valvular lesion है, मरमर आ रहा है, मरमर आ गया उसको. Now कितना दोगे prophylaxis? Options 40 year or 28 plus 10, 38. What is the right answer? 40 year or 38? 40 year or 38? Tell me. Give me. Yes, we'll go for 40. So we will go for 40 years. Yes. Now comes the topic of infective endocarditis. So the most common cause is Staph aureus. So the most common cause, Staph aureus is the most common cause. It is oral most common. It is coagulase positive. Okay, but if it is subacute, it is Streptococcus. If it is a native valve, it is Staph aureus. But if it's a prosthetic valve in which you are having some artificial valve after replacement, then it is epidermidis, again staph, but it's coagulase negative. Okay, so remember, If coagulase and catalase positive, we go for Staph aureus. If they are saying coagulase negative, go for epidermidis. If native natural wall is affected, Staph aureus is the case. What the organism? Staph aureus. If prosthetic, epidermidis. If IV drug user, most likely right side endocarditis is there, and Staph aureus is again more common than enterococcus. So it could be enterococcus, but it is Staph aureus. Okay. Done? Okay. Now we use what is called as modified Duke's criteria. What we use? Modified Duke. It is basically two major criteria: blood culture and echo finding. So what are the blood culture? Remember, either see, please remember, ask multiple times, 2 positive 12 are apart, 2 positive 12 are apart, or 3 positive but 1 are apart. So if you are taking multiple sample, let's say after 12 hour, 12 hour, 12 hour, if any 2 come positive which are 12 hour apart sample, then it is positive, major finding. Or if you are taking 1 hour apart sample, at least 3 should be positive, at least 3 should be positive. Also echocardiographical evidence of what? Endocardial involvement, like abscess is there, oscillating mass, valvular lesion. So if you see any of these, they suggest there is some, yes, valve involvement. Okay, so that is the 2 criteria: valve involvement or blood culture. Minor is again fever, there is temperature, immunological phenomena like oscillatory rot, which I'll discuss very soon, microbiological finding like blood culture but not 12 hour apart, embolic phenomena like formation of multiple emboli which go to multiple part causing hemorrhage, thrombosis, and finally risk factor like IV drug user, congenital heart, or prosthetic valves. These are minor. Major is 2. Blood culture. What are the criteria? Let's ask you. What is the criteria for blood culture? Bata do bhai. Blood culture. What are the criteria for blood culture? Tell me. Very good. So 2 12 hour positive or 3 positive, what apart? One hour. Please remember them. I'm not joking. Minor या फिर और echo. Minor is fever or hemorrhage or emboli, micro, immuno, and risk factors. Risk like valves or drug user. These are the minor ones. These are the minor ones. Okay. Now, what is the findings? They are basically vascular findings, mainly vascular findings. So, Josh Rahe. So, mnemonic hai, how's the Josh? Josh Rahe. So, J for Janave lesion. So, when someone is on the way, क्या बोलते हैं? Ja. So, ja is palm. So, ja is palm and your problem is gone. So, painless. So, if painless lesion in the palm, it is called as Janave. So, they are in the palm, painless. Then, if doctors are asked, what we do? We put finger in the opening, oslar. Os is opening. We put finger in the opening. Os means opening, na? So that's why finger डालेंगे तो patient को pain होगा, ऐसे याद कर लो. So painful swelling in the fingertips is called as oslar node. So it's painful. That's the question. Then splinter hemorrhage. Like when some wooden, let's say you're playing with ply wooden on the table chair, and sometime what happens? The small pieces of wood get under your nail and cause hemorrhage. This is called a splinter hemorrhage. So what's a splinter is? It's a small red color streaks. Can you see? So this red color streaks in the nail bed is called as splinter hemorrhage. And also there is a hemorrhage in the retina called as Roth spot. Retina Roth spot. So this is Roth spot. So Janave, Osler, splinter, Roth. So all of these are the findings that we can see. So that is the case. Okay. Next question. Treatment is IV antibiotics based on sensitivity. So we'll do culture and we'll do sensitivity. If MRSA, MRSA, we go for vancomycin. The side effect is Redman syndrome, MCQ. So Redman syndrome is by vancomycin. If it's a VRSA, there is vancomycin resistant staph aureus, we go for daptomycin. And remember, if it's a lung infection, don't give daptomycin as it is broken by surfactant. We go for linezolid. We go for linezolid. Okay. So lastly, we'll do hypertension. So I'll take a break now. Okay, 15 minutes break. Okay, so I'll eat something because I've not taken my lunch. 15 minutes. We'll start at sharp 7:50 p.m. Okay, so 7:55 p.m. Okay, so let's meet at 7:55. Okay, let's continue. We'll study hypertension. Hypertension, angry person. Please join in. Am I audible, visible? Yeah. Hello, Dr. Anju, Nandini, creating happiness, Neha. Yes, hello to everyone. Please join in. Okay, let's continue. Yeah. So this is what hypertension look like. Can you see? Red, flushed face, very red. This is what hypertension does to you. So let's start. What is hypertension? It's a silent killer. Reason? Very few or almost no sign. Like maybe I'm hypertensive, but there are no features in me. So that's why it's almost featureless. So it's what? Very few or no sign or symptoms. So that's why it's a silent killer. Then there is also headache, sleep disturbances, polyuria, etc. Due to what? Pressure diuresis. What is there? Pressure diuresis is there. Okay. Also, there is going to be a irritability. All are seen. All are seen. Plus, there is a redness over the face, mainly cheek area, called as malar flush. It's not a rash. It's a flush, redness over cheek, and also sleep disturbance. Okay, all. Now, what is the iceberg phenomena? Very few patients are actually detected, and out of the ones who are detected, diagnosed, very few are given treatment. So very few are actually treated. So few are treated. That is why rule of half is there. That is half are diagnosed, half are detected, then diagnosed, then given treatment, half take it properly. So very few actual get the proper treatment and care. Prevalence around 29.8% is the prevalence, and 40 crore Indians out of 145 have hypertension. देख रहे हो कितना high value है. Now males are more than female, again multiple reasons, but remember after menopause even females can have hypertension, same as the males. Okay. BP estimation. So best and most accurate is intra-arterial BP recording. What is that? It is intra-arterial BP recording, but it's an invasive method. So but it is invasive method, so we use less this, and we use mainly it in ICU. What is preferred? Sphygmomanometer, which give you the BP recording. Okay. Now next question. This I skip, no need to learn. So what is the best method for BP estimation nowadays? It's 24 hours ambulatory BP recording. What is white coat hypertension? Increased BP on seeing a doctor or medical professional is called as white coat hypertension. Now diagnostic criteria, JNC has been discontinued, no longer it is there, but still we use the criteria of JNC. Systolic 140, diastolic 90 is hypertension, and now we use American Heart Association AHA guidelines. It is now followed even in India. It's a 130/80 is hypertension. If they don't give 130/80, you can mark 140/90 in the exam, but I'm telling you now it is accepted to be 130/80. Reason? If you wait for 140/90, maybe it is causing already complications. So now we start managing the hypertension from 130 onwards. Okay. Normal is 120/80, hypertension is 130/80 plus. Okay. Then pre-hypertension is systolic above 120 but less than 130, and diastolic 80 below is normal, above 80 is pre or hypertension. Hypertensive crisis is 180/120, 180/120. Okay. Now this is a AHA classification. 120/80 less is normal, pre or elevated is 120/129 or less than 80, but if it goes above 80 or above 130, it is high blood pressure. 140/90 is stage 2. So which is the JNC criteria? As per JNC, this was pre-hypertension. These two were pre-hypertension, and this was hypertension as per JNC. But now American classification has changed slightly by 130/140 funda. Now if only one BP is high, other is normal, it is called as isolated hypertension. What is it called as? It is called as the isolated. So what is it called as? It is called as the isolated hypertension. Now, types of hypertension, it could be primary or it could be secondary. What is primary also called as? It is called as essential hypertension. It is mostly idiopathic. It is what in nature? Idiopathic in nature. So what is idiopathic? The primary. Why? Because there is no, disease which is causing it. So we don't know. It's unknown. And possibly it will be environmental or genetics or lifestyle. They are responsible for primary. Now secondary is due to other diseases. Most commonly it is renovascular diseases like renal artery stenosis. Here there is a very little blood flow which causes the increased BP via RAS. Okay, so that's why ACE and ARB is contraindicated in renal artery stenosis. MCQ. So remember this. In renal artery stenosis, never ever give ACI. Never ever give ACI. Then in glomerulonephritis, okay, example nephritic syndrome, PSGN, IgA nephropathy or polycystic kidney disease, all of these conditions, again, what is there? There is going to be, yes, our hypertension due to kidney involvement. Then endocrine causes, pheochromocytoma, Cone, Cushing, acromegaly, then Graves, thyrotoxicosis, we have discussed already. Others are SLE, pregnancy, preeclampsia, MI, coarctation of aorta, polyarteritis nodosa, aortic dissection, scleroderma, PCOD, drugs. So many things are there which can cause hypertension. Okay. Now complication, very important. Arteriosclerosis. As the pressure increase, the arteries are stretched too much, which can damage their, layers and cause the hardening, calcium deposition, which cause arteriosclerosis. So arteriosclerosis, then hypertrophy of left ventricle, and then it can even fail. So that's why long term it can cause a failure. Then malignant nephrosclerosis. So malignant nephrosclerosis, what does it show? It shows the very famous flea bitten kidney. Okay, it's not beaten, it's bitten, not beaten. Flea beaten kidney. Okay, as if the flea has beaten. Remember, which caused the this plague, Yersinia pestis. So this Dinospora chiopsis is causing this. So you see red dots on the kidney. These red dots are because of hypertension causing small hemorrhages. Okay. Also, there is retinal retinopathy. So hypertensive retinopathy show Sallu sign, gun sign, bonnet sign, copper and silver wiring, AV crossing, and flame hemorrhage, flame shape hemorrhage. They'll be covered in ophtha. So which hemorrhage? Flame shaped hemorrhage. Now comes the question, putamen. What is the most common site of the cerebral hemorrhage stroke? We have discussed it already. It is putamen. I've discussed that something already. Chalo. Now this is Sallu, gun, bonnet sign seen in hypertensive retinopathy. We'll skip it. Now treatment. Most effective is weight loss. Most of the hypertensive are, yes, having obesity. Then lifestyle modification, just similar to diabetes, avoid stress, meditation, exercise, stop smoking, stop alcohol, and then DASH. What is DASH? Dietary approach to stop hypertension. So what is the dietary approach to stop hypertension? So dietary stop with this approach to stop hypertension is our, yes, DASH. Now what is the funda about DASH? It can decrease our BP by 8 to 14 mmHg. So how much is the reduction? It is 8 to 14 is the value. So what is the value? 8 to 14. Okay. Then what does that include? It include decreased salt intake, 2.3 gram per day, less. Okay. And if age is more than 50, diabetic, hypertensive, then the recommendation is less than 1.5 or 2.3 is others. Now also reduce saturated fat in the diet, red meat, cholesterol rich food like red meat only, and also correct dyslipidemia via statins. Medical treatment is given when the BP crosses 140/90 mark. So when it goes above 140/90, we'll go for medical treatment. What are the medical treatment? First line drugs are ACD, ACE inhibitor, CCB, that is dipins, and diuretics, mainly thiazide. So what is the main ACE we are using? Valsartan is very commonly used. Then amlodipine, nicardipine, clavidipine is used. And also what are we having? We are having this flow chart. If younger patient less than 55-60 year or diabetic, drug of choice is ACE. 100% exam question. Diabetics or less than 50 should go for ACE. If it's the older person, start CCB. So remember, younger person ACE, diabetic ACE, nephropathy ACE. If older person without any of these, go for CCB. Now if it doesn't work, if fail to correct BP, if fail to correct BP, then we will go for A plus C. That is A plus C. So ACE we add the CCB or CCB we add the ACE, and still fail we go for 3 drugs A, C, D. And if 3 drugs fail, it is a resistant hypertension. The treatment of resistant hypertension is obviously we give spironolactone. MCQ. So drug of choice for resistant hypertension is spironolactone. Okay. Now we'll discuss hypertensive crisis. If the BP cross 120, 180, 120, it is crisis. Urgency versus emergency. In urgency, there is almost no sign symptom, no end organ involvement. That is, there is no kidney disease or no stroke or no heart or any other organ involved. That is why it is called as urgency. We can manage it in OBD, give the drug to the patient and decrease the BP to normal within next 24 to 48 hours. That is gradually decrease. Okay. In emergency, E, sign symptoms, organ involvement. So that's why main is E, and organ involvement like heart, brain, kidney, even pregnancy, pheochromocytoma. Now remember, we need to get this patient admitted and bring the BP to normal. How? First question, if it's a PAP, what is PAP is? Pheochromocytoma, preeclampsia or dissection of aorta, PAP, PAP, pheochromo, aortic dissection and preeclampsia. We need to decrease BP to normal, that is less than 140/90 within 1 hour. Other diseases like maybe stroke is there, kidney failure or pulmonary edema, then we decrease BP 25% in first hour and then try to reduce it back to normal within 24 to 48 hours. So remember, if there is a urgency, so I'll just write urgency, just give drugs and ask him to decrease BP, just monitor the BP, drugs monitor and normal BP in 24 to 48 hours. Okay. Emergency, admit, normal BP, in 1 hour. Normal BP in what time? In 1 hour we want a normal BP. Are you clear? So normal BP should be there in 1 hour. Okay. So 1 hour normal BP. Okay. If PAP, what is PAP? Pheo, aortic dissection and preeclampsia. Please भूलना नहीं है ये, very important topic. Others 25% decrease in first hour. So other condition, decrease BP by 25% in first hour. Okay, please remember them. It's a very important topic and I'm not joking. Every year question come from our hypertension. It's one of the most famous, most important topics. So are you clear? So hypertension is very important topic that we need to discuss or do. So clear? So that is a story. So are you clear? Done? Yeah. Okay. So let's start. Now, so what do you give in pre-eclampsia? So what are we going to give in the condition of pre-eclampsia? So क्या करना है preeclampsia में? Let's start. So we give IV labetalol. So what are we giving? We are giving IV labetalol in this case. Okay. Then if it's a pheochromocytoma, again labetalol plus we can give phentolamine or nitroprusside. I discussed that already in the topic of our pheochromocytoma. So that's not something new. We have discussed it already. Okay. Next question. If it's aortic dissection, we go for asmolol MCQ and we can add a CCB. So asmolol plus CCB, like okay, nicardipine can be given. Okay. Then if it's a MI hypertension, then again BC, that is asmolol plus nicardipine. So these are beta blockers we are giving and the CCB. If it's a cerebrovascular disease like stroke or subarachnoid hemorrhage, again labetalol and CCB is preferred. In kidney disease, renal disease, we are going to go for our phenaldopam. So what we are going to go for? Phenaldopam is the treatment we will be giving or having, which is the dopamine agonist. So what is phenaldopam? Phenaldopam is the dopamine agonist. What is the phenaldopam, which is a dopamine agonist, going to do or work or this? So clear? So that is the funda here. Are you clear? Okay, just 1 minute. Okay, I'll come. 1 minute. Okay. Oh yes, let's continue. Okay, so let's see next. If there is a, yes, kidney disease, we go for phenaldopam. So kidney disease treatment is phenaldopam. Now, if there's a pulmonary edema, then we are going for systolic dysfunction. What is there? Systolic dysfunction, or maybe there's a diastolic dysfunction. If systolic disorder, don't give beta blocker, we know, because pumping will decrease. So we give the CCB plus loop diuretic furosemide plus nitroglycerin. In case it's a diastolic dysfunction, then we are going to give beta blocker, loop and NTG. Now we'll discuss aortic dissection. Remember the word which I am telling you. What is aortic dissection? It's a tear in the aorta. So blood rushes between the two layers, intima and media, creating a false lumen. There's an important question. You can see a false lumen with blood inside. This is the case. So it looks like yin and yang or tennis ball. Can you see that? So this is your false lumen and blood inside the aorta. It has multiple effect. Blood will not reach the organs. Okay. Plus it can increase the blood pressure. So that's why there could be hypertensive crisis, or you can say emergency, and the pain radiate backward. That's the main thing. Tearing sharp pain which is radiating backward. BP can be high or low. If it's in shock, can be low, or BP can be very high. And investigation, we do MRI or transesophageal echo. So remember, again, echo is done if available as soon as possible. CT can be used, but again, CT MRI takes time. So esophageal echo is the preferred one. Classification is DeBakey's or Stanford classification. This is a DeBakey or Stanford. So this is the one. Okay, DeBakey's. So they are saying which type is there, ascending, descending, which part. So that is called as the DeBakey's. Okay. So type A Stanford is ascending aorta and can goes to arc and descending. B, it doesn't involve the ascending. So that is Stanford classification. DeBakey's is basically 1, 2, 3, 4, depending on 1, 2, 3. 3 is 2 type A and B. So total 4 types are there, 1, 2, 3A, 3B. Okay. Now what are the management? So remember, we have to give oxygen as soon as possible. We need to give the oxygen, plus we need to give IV fluids if shock is there, and decrease the BP if there is a this. So target is less than 110 mmHg is the decrease. So what do you decrease the BP with? Yes, we decrease the BP with esmolol, labetalol, that is beta blockers. Okay. Then second line is CCB, depends. Okay. Surgery is only done if there's a complication or yes, problem like severe ischemia of the limbs, then we might need a surgery. So we can do surgery. Okay. Chalo. Next is shock. What is shock is? Shock is a reduced tissue blood flow. If BP is less than 90, it is uncompensated shock. If BP is above 90, 60, despite loss or pathology, is called as compensated shock. So types are very important. Hypovolemic shock. There's a loss of fluid blood in the body, dehydration, vomiting, hemorrhage. So low blood volume, all volume pressures are low. Remember, a mnemonic, all volume pressures are low. All volumes and pressure low. That's a rule here. Okay. Heart rate will be high. Heart rate is high because of compensation. Heart rate is high. Treatment is a cold shock because the blood is not going to the skin. So we give IV fluids, blood. Urine output monitoring is done for treatment and prognosis. So what is treatment prognosis done? On the basis of urine output is for prognosis and treatment. For the fluid intake, we can use CVP. CVP indicate fluid demand. Fluid correction needed. MCQ. So we give fluids till the CVP increases. Okay. If oliguria persists, we can add dopamine. We can add the dopamine. Okay. Next, we calculate shock index here. I think it's here, not here. Yeah, this shock index. So what do you calculate? We calculate shock index. What is shock index basically? Heart rate normally is less than this systolic BP. Like heart rate is 70-80 and our SBP is 120 normally. So it should be giving what ratio? Around 50% or 60%. If there is increased heart rate and decreased BP, that indicate our shock. So that's why if it is more than 1, it's hemodynamically unstable. Okay. If there is a modified shock index, we take the MBP. MBP is modified shock index, we take SBP. So SBP, we take this. Next question, let's come back. Cardiogenic shock, again low BP, increased heart rate. It is due to heart failing to pump the blood, and findings I discussed already. It's a cold shock. Okay, it's a cold shock. Skin doesn't get the blood, skin is vasoconstricted, but there is an increase in JVP, CVP, S3, edema. Pressure volumes can increase. Treatment is noradrenaline. Treatment is noradrenaline. Now, distributive or warm shock. Basically, what happens? There's a vasodilation, so the blood accumulates in vessel. That's why the body is warm. So why warm? Because blood is there. In hypovolemic and cardio, body is cold. Why? Blood is not pumped by heart or not reaching the body, and that is the case. Treatment is vasoconstrictor, like adrenaline is the drug of choice here. So first type of warm shock or distributive is anaphylactic shock. So allergen like insect, bee sting, food, most commonly shellfish, very common, peanuts. Histamine release occur because of antigen binding the Ig. Remember, so antigen bind Ig, then it causes the mast cell to release histamine, which cause vasodilation, that cause the warm shock. Plus there is a decreased BP because blood will stay in the vessel, not go to heart. Heart can't pump. Rash is there, itching is there because of histamine, bronchospasm, all are done by histamine, and that is also having this bronchospasm. Wheezing is there, so there will be a wheezing story. And also there is a edema, swelling on the face, lips, etc. Next question, drug of choice. So drug of choice is adrenaline. Okay, alpha 1 causes vasoconstriction. So the alpha 1 causes vasoconstriction and also bronchodilation, that is beta 2. Okay, that is why we prefer adrenaline. How much? If you are giving subcutaneous or IM, 10,000 is the 1000 is the ratio, 0.5 ml. If you are giving IV, you should go for 10,000. Okay. Neurogenic shock, basically what occurs is the loss of sympathetic activity, mostly spinal injury. And remember, hallmark, there's a decreased BP, decreased heart rate. So if there is a spinal injury with decreased BP, increased heart rate, it will be hemorrhagic hypovolemic shock. If both are low, सस्पेक्ट न्यूरोजेनिक शॉक. ये एग्जाम में क्वेश्चन आया था आपका, FMG एग्जाम 20 Jan. दिस क्वेश्चन वाज देयर. रोड ट्रैफिक एक्सीडेंट, डिक्रीज बीपी, डिक्रीज हार्ट रेट. इट कैन नॉट बी hypovolemic shock. It is neurogenic shock. Okay. Example, treatment again, noradrenaline. So neurocardio, noradrenaline. Neurocardio, noradrenaline. Anaphylactic shock, adrenaline. Okay. Septic shock is basically cardio plus distributive. Here what happens is, again, heart rate is more, BP is low. Heart rate more, BP is low. Okay. What happens? The bacterial endotoxin inhibit the myocardium, decrease the pumping, sympathetic increase the heart rate, plus there is the vasodilation. What is the result of vasodilation? This vasodilation causes again distributive shock. Treatment again noradrenaline plus IV antibiotics. Finally, vasovagal shock. So remember, what to shock heart rate is low. ये आपके एग्जाम के क्वेश्चन है. किन दो शॉक में हार्ट रेट कम होती है? एक तो न्यूरोजेनिक बिकॉज ऑफ लेस सिंपैथेटिक एंड वेजोवेगल बिकॉज वेगस इनहिबिट द हार्ट. सो इफ दिस एवर अ क्वेश्चन ऑफ डिक्रीज हार्ट रेट, please it's neuro or vagal. Others the heart rate is increase. Other heart rate is increase. Drug of choice is atropine. Drug of choice is atropine and triggered by cold water, drowning, fear, cholinergic drug, even air probing. So when you are probing the air, you can activate the Arnold's nerve, which is vagus branch, and that causes our vasovagal shock. So remember, warm shock are these three. These are warm shock. And these are cold shocks. ये सारे आपके एग्जाम के क्वेश्चन है. Cold, warm, and what happens here? Bradycardia. So what two condition? Bradycardia is there. Bradycardia occur in neurogenic and vasovagal. Neurogenic and vasovagal. चलो, last is cardiomyopathy. What is the story about cardiomyopathy? So first question, there is abnormal muscle structure and protein, that is cardiomyopathy. What are the types? Three types: dilated, restrictive, and hypertrophic obstructive cardiomyopathy, HOCM. Now what happens? In dilated cardiomyopathy, there is what? There is a systolic dysfunction. Heart is unable to pump. Most likely it's due to damage to the myocardium. So heart can't pump the blood. So chamber is enlarged. which resemble congestive heart failure. So what it resemble? It resemble our congestive heart failure. So what it resemble or copy looks like? It look like our congestive heart failure. Now investigation and treatment are same as congestive heart failure. Inotropes are given or in the end heart transplant or some ventricular assist device. Chalo. Most common causes is actually is a controversy. Some books say alcohol is the most common cause, some say infection, but it is infections are more common. Okay. Then drugs like doxorubicin, which is again a cardiotoxic drug, pheochromocytoma, stress, increased sympathetic, or even that very famous Takotsubo, cardiomyopathy. Also beta 1 deficiency, which is beriberi, wet beriberi, myocarditis, they all can, MI, myocardial infarction, they can all cause our dilated cardiomyopathy. Restrictive is similar to constrictive pericarditis, poor filling, Kussmaul is positive, XY both are prominent. So it's very similar. Okay. Treatment is beta blocker to decrease the heart rate, improve the filling, and correct the cause if you know the correctable cause. And pathophysio is mainly infiltration of the myocardium, amyloid deposition, glycogen storage disease, or anything which prevent the ventricle from stretching and filling with blood. Most important 100% exam question is HOCM. Yaad karna, HOCM is autosomal dominant. It is very commonly seen in young people. So that's why history होगी जिसके father को भी थी and father died because of this young age 30-40. So if a young person there's a sudden death, okay, without apparently any other feature, or an athlete collapsing and dying, most likely it could be HOCM. There's a mutation in chromosome number 14 which is coding for myosin heavy chain. Now because of the mutation there is a increased thickness of IV septum. This is IV septum. So this IV septum become thickened. As it become thickened, what does? It obstructs the aortic outflow, and that's why it's similar to aortic stenosis. So it's the brother of aortic stenosis. So this hypertrophy causes the obstruction and similar to aortic. So murmur is also same, MSM and ejection click. Plus he is very sad, syncope, angina, dyspnea. Then double peak pulse. There's pulses bisfrequence is seen. Double peak, I'll show you. This is double peak pulse. So normal peak is like this. This is normal peak. This is double peak. So double peak pulse is seen in pulses bisfrequence. Okay. Also the ventricle appear very narrow in the lumen because of the hypertrophy. So look like a banana. So yaad kar lo, banana ventricle dilated to ho gaya dilated. If ventricle is very narrow and long, it is banana shaped ventricle. So which ventricle? Banana shaped ventricle. Okay, banana shaped ventricle. Treatment is myomectomy. We need to cut the this IV septum, or we can even destroy by injecting alcohol. So we can, yes, inject alcohol in the septum and destroy. Final treatment is heart transplant if there is a failure of the pumping ability. No drugs are used. No drugs used. All drugs are contra except beta blocker, and avoid exertion. That's very important. Okay. Now we see very famous Takotsubo cardiomyopathy. So what is this Takotsubo cardiomyopathy? So this Takotsubo cardiomyopathy is basically look like a octopus. It look like a octopus who's coming out of the jar. So it is called as the Takotsubo. What happening is basically very common in female. तो याद करना female को होता है और due to stress. That is why it is called as what? Broken heart syndrome. What is it called as? Broken heart syndrome. So there's a stress which increase neurogenic factor like high sympathetic, and it causes also coronary spasm. Spasm decrease the blood supply which cause the angina pain, plus myocardial is unable to function. So stunning and hypoactivity cause decreased pumping. So it cause a reduce cardiac output. So it cause a heart failure. So these are the features. Okay. Now it resemble which two condition? It resemble our coronary artery disease. So there's a ST elevation, T inversion, Also increase cardiac enzyme. Troponins increases, ejection fraction decrease, which indicate the cardiogenic, shock like condition. And there's a history of stressful event. Okay, very good recovery. Then there is poor pumping, that is wall motion is there, plus coronary artery is okay, is not narrow. So you do an angiography, you might not see anything because there's no thrombosis, there's no atherosclerosis. That's why it can be normal. But there is a spasm. That is the problem. Okay. Next question. Okay. There is ECG changes plus troponin increase, which mimics MI like features. Okay. So symptoms are obviously chest pain, angina. Then there is also dyspnea, palpitation, syncope, and which shock? Cardiogenic shock. This is the ventricle where you can see thrombus formation also, and you see an area where the ventricle is dilated. So it look like that bag in which octopus is coming out. That is what cardiomyopathy is. Are you clear? So this part is, yes, not able to contract, it get dilated. Thrombus can also be seen. That is the case. Treatment is very similar. We have to give beta blocker. Okay, we can give diuretics, alpha 1 stimulant drug. Then we can, yes, do AIBP. Okay, main is beta blocker. What is the main treatment? Beta blocker is there. Surgery can be done. Okay, so that is the case. Yeah, we'll go on 18. Yes, Jai, 100% will go. Okay, now I will do kidney first rather than respiratory because it will take more time. Okay, so let's do kidney first. Once we finish the kidney, we can come to respiratory system. So I am doing nephro first. Okay, because nephro take less time. Okay, so let's do nephro first. Okay, so first is in the nephro. What does kidney do? It clean the plasma by removing the waste through filtration and secretion. Good things are reabsorbed, bad, that's the case. Okay, now there are three types of renal diseases: pre-renal, renal, post-renal. So what are the three diseases? Renal, post-renal, pre. Pre-renal is basically poor renal blood flow. If kidney doesn't get the blood, like shock, congestive heart failure, MI, or any kind of, like sepsis, cirrhosis, if kidney is not getting the blood flow, it is pre-renal condition. What condition? Pre-renal. Okay, after kidney we'll take a break, I think another 30-40 minutes, then we'll start the respiratory. Okay, GIT and this I will do as a special session in MCQ format. Okay, so I'll discuss the portion of hepatitis, Crohn's, all this, and I'll be covering that part. Okay, so I'm not going to take GIT here. GIT hematology will take in pathology. Are you clear? So GIT hemat will do as a pathology separate system. Okay, so today target is, let's finish the nephro, then do the respiratory and call it a day. Okay, class will be till 10:30, so I think by 10:30 we'll be able to finish everything. Okay, so let's continue. Okay, then if problem is in kidney, is also called as intrinsic renal or our, yes, renal failure. So there are tubular diseases, tubular, glomerular diseases, vascular diseases, interstitial diseases like interstitial nephritis or, yes, infections. Okay, post-renal, kidney is okay, but there is an obstruction which could be in the kidney like intrarenal nephrolithiasis, or it could be extrarenal, outside the kidney, like stone in the ureter, or maybe prostatic hypertrophy. This is BPH. Prostate is very big. So these are the types of disease we are having. Now, so what is the summary? Kidney has three kind of disease: pre-renal, renal, and post-renal. Okay. Now, if kidney cannot function, there would be accumulation of what waste? Nitrogenous waste like urea, uric acid, creatinine. This is called as azotemia. What is it called as? Azotemia is the term. Azotemia. Now KFT, I'll make it easy for you. So that is the case. Yeah, tomorrow also we have a class. Tomorrow we'll do surgery. Okay, so we'll do surgery tomorrow, and day after tomorrow we'll do the, I think, patho, pharma, all. So I'll check my schedule and see what are we having. Okay, so tomorrow we'll do surgery. Okay, chalo. KFT. So first question, what is the serum urea? So serum urea level is around, yes, what value? It is around 20 to 40. 20, yeah. Okay, Optha, we can do tomorrow. It depends. Tomorrow kya karna hai? So we will check and do. Okay. So clear? One second, okay. One second, okay. One second, okay. Just messaging regarding the schedule only. So just messaging regarding schedule. Just give me a minute, okay. Chalo, okay, sorry. Again, very difficult to discuss about the schedule, etc. Yeah, so I just discussed the schedule and I'll come back. Okay, fine. Chalo, let's continue. Okay. First is KFT. What is KFT? Kidney function test. In kidney function test, there is serum urea. The serum urea is 20 to 40. Okay, yeah, we'll take surgery. Surgery I'll start early. Tomorrow I'll try to start 3 p.m. and go till 8 p.m. I have a flight in 11, so I can finish by 8 p.m. So I'll try to do as fast as possible. Chalo. KFT. What is KFT? Kidney function test. So kidney function test. Serum urea. What we check first? Serum urea 20 to 40 mg. And if you divide by 2.8, we can convert it to millimole per liter. So how do you convert it to millimole per liter? ठीक है, चलो. Let's continue. Okay. Now, what is the serum uric acid? It is 4 to 8 milligram percent. Serum creatinine is 0.5 to 1. Okay, 0.5 to 1. Okay, abnormal if it is above 1 or 1.2. Then blood urea nitrogen is roughly half of blood urea. So it's blood urea 20-40. So half will be 10 to 20 milligram percent. So it will be 10 to 20 milligram percent. Then urine creatinine and serum creatinine ratio is 10 to 20 times. So 10 to 20 times. Okay, 10 to 20 times. Okay, fine. So 10 to 20 times. Then comes BUN. What is BUN and serum creatinine ratio? It is 10 to 20 times is the BUN. Okay, 10 to 20 times. Okay, then serum sodium, okay, is again similar to this. So urine sodium is 10 to 20 millimole per liter. So it's 10 to 20 millimole per liter. And urine specific gravity is also 1020, like 10, 10, 0, 1020. So the most common value we see is 1020. So let's see what is that. What is the value of BUN? 1020. Yeah, value of urine creatinine, serum creatinine 1020 times. BUN creatinine ratio 1020 times. Urine sodium 1020 millimole. Urine specific gravity 1020. So that is urine specific gravity value. So which value? Urine specific gravity value is there. So I hope is clear. So these are all the values we will see, discuss or have. Okay. Okay. Now ADH I discuss in physio. ADH cause what? ADH. So ADH causes water absorption. As it causes water absorption, it causes concentrated urine formation. So which formation? Concentrated urine formation. Second question, it act via V1 which cause vasoconstriction, okay, and V2 cause increase aqua pulp, okay. Okay, in collecting tubules of kidney, okay. Next question, P cell in the kidney collecting duct, they absorb the water and causes low volume concentrated urine. So which volume? Low volume concentrated, okay. So are you clear? So that is the story here. 600 to 1200 milliosmol per liter. Are you clear? Then range of urine osmolarity. Hypotonic means less or no ADH. It is low. That is as low as 50 to 100 milliosmol per liter. Hypertonic is 600 to 1200 milliosmol per liter. So what is the value? 600 to 1200 is the case. Clear? So that is our case. So clear? Chalo. Next question, urine volume. Normal urine volume is 1 to 2 liter per day or 40 to 60 ml per hour. So what are the values? 40 to 60 ml per hour is the value. Now weight wise it is 1 ml per kg per hour. So how? Example, a person weight is 60 kg. 60 kg make 60 ml. So that give 1 ml. So that is how you get 1 ml. Clear है? ठीक है. So clear? Okay, let's continue. Now, if there is a kidney injury, the value will fall half, that is 0.5 kilogram per hour. In renal failure, it will be 0.3 ml per kg per hour. Oliguria, it will be 400 ml per day or less. In polyuria, it is 3 ml per day or more than 2 ml per kg per hour. So these are our values that we can see and have. Are you clear? So clear? Now comes a question DI and SIADH. So DI and SIADH. Now, what is DI? DI is our diabetes insipidus, neurogenic or nephrogenic. Okay. Okay. So neurogenic or central DI, less ADH come from pituitary. What is the normal? 1 to 5 picogram per liter. If it's less than this, it is called as neurogenic DI. Example, any lesion of pituitary. Nephrogenic DI, normal ADH but fail to act in kidneys. And there is a receptor defect in this case. Clear? So receptor defect is the case. So receptor defect is there. So what defect is there? Receptor defect is there. Okay. Now, what is the clinical feature? Without ADH, there will be less water absorption. If there is less water absorption, there will be more urine. So polyuria, polydipsia, dehydration is there, and there is the case. Okay. Can I take a break of 10 minutes? Okay, to reply. Okay, so many chats are coming. Just give me 5 minutes break. I'll come and reply. Okay. Okay. I'll just come in 5 minutes. Okay. There is some issue right now. Okay, I have to go. There's a meeting regarding this NMC notice, so I'll go and attend. Okay, and I'll continue tomorrow early 3 p.m. and we'll finish this. I think we need 1.5 hours. Then I start with surgery. So we'll take 6-hour class tomorrow. So we'll take 6 hours tomorrow. From 3 to 9 p.m. First, we'll do the medicine part 4. Sorry for taking fourth part, but again, I was helpless. And then we'll do optha or surgery. It's up to you. You want optha or surgery? What I should take, optha or surgery? Tell me, optha or surgery is up to you. Yeah, I'm just going to have a meeting. They called me. They want to meet me before they want to go there. So I'll go and talk. Okay. So I think I'll have a look at the notes. Whatever is possible, I'll finish. Okay. We need 5 hours for that. So I'll take 5 plus 6 hour class and finish everything. Okay. Clear? Chalo, don't worry. Tomorrow we'll take that. So revise now. Okay. PDF is already there in G Drive. You can have a look at the G Drive. ये G drive है आपका. In G drive just open the race PDF. In race PDF you will find all the PDF there. I'll put this latest PDF also. All the PDF are there. Endo, pharma, this neurology, all, and I will add others also. That's up to you. Okay, chalo. So I'll end the session. Let's meet tomorrow. Okay, take care. Bye bye.